Proximal Junction Kyphosis. And we have some very interesting articles, and we also have some great literature to review. And we're going to kind of talk about everything: prevention, definition, classification. And our first speaker is Zach Tatarin. Before I start, I just want to quickly recognize and give a moment of silence to Dr. Preston Phillips. I actually met Preston through SSF. He came up to me at a course. He used to be a practicing orthopedic surgeon at Swedish. And Jens, I think you knew him better than I did. I met him once. Sadly, he was murdered by one of his patients. I think everyone saw it in the Wall Street Journal. And you know, he'd come up to me, and we were at a course, and he said, "Hey, I'm Preston Phillips. I've seen you on SSF TV." And he'd watched all our videos. Great guy. I personally didn't know him that well, but I think Jens and some of the other orthopedic surgeons knew him. It's kind of a tragedy, but I just wanted to recognize Preston and also SSF. I mean, it shows you the power of education and technology. So,
hey, Rod,
yeah.
Can I just quickly add on that? So I'm sorry I couldn't be there in person. We're at Global Spine Congress with several of us here in Vegas. Dr. Preston Phillips was an eminent and outstanding member of our community here in Seattle. He left in 2006 to go back to Oklahoma, where he was from. Not only was he a very caring spine surgeon, he was a truly compassionate human being. And the senselessness of these murders is personified in him. This is a man who felt very fortunate to be able to give back to the community, and felt very fortuitous that he had such a great background with education at Harvard and a premier education, including spine surgery. And he annually gave back by going to Togo in West Africa and doing volunteer work there, unreimbursed, of course, and initiated and organized on his own cost by himself. So I was just struck as a fellow orthopedic spine surgeon, who was at the time at the University of Washington, with how incredibly compassionate and caring this man was. And again, the murder of him, just like children and other innocent civilians, is just really shocking and saddening, and clearly also a reflection of the very poor mental health of our country. I'm going to stay out of other things, but I want to personify this on Dr. Preston Phillips, who at the premature age of 59, and any age is premature for that matter, was murdered in cold blood by somebody who clearly was deranged in the thought processes, and struck people who were very eminently involved in the process of caring for their fellow human beings. So thank you for allowing me to intercede for that. I appreciate that you made that mention of Preston, and we will miss him, and we will very closely hold this memory high, and obviously send our thoughts to his family. So thank you, and for hosting this live Rod.
Thanks, Jens. So Dr. Zach Tatarin is going to talk about PJK. He's also going to talk about definition, classification, and risk factors, and prevention.
Good morning, everyone. I'm Zach, neurosurgery spine fellow here at Swedish. This is a lit review of proximal junctional kyphosis, proximal junctional failure. I'll try and stay on time. This is just a general overview of those. And the subtopics are covered in more detail in the further papers later today. So there's no universally accepted definition for proximal junctional kyphosis, but the most common one, and the one that's utilized most frequently, is a proximal junctional angle greater than 10 degrees, that is at least 10 degrees greater than the preoperative measurement. Risk factors can be classified patient-related, radiological, and surgical, and prevention strategies are critical. So, introduction. PJK, development of kyphosis at the transition between fused and mobile segments in the adult spinal deformity area. It's considered a radiological phenomenon, whereas proximal junctional failure is a progression of PJK, and it's actually the clinical manifestation of this. And as I said before, the common definition is sagittal Cobb angle greater than 10 degrees that is at least 10 degrees greater than the preoperative measurement. So as I said, PJF is a progression of PJK. It's associated with structural failure, adjacent vertebral body fractures, posterior ligamentous complex development, and vertebral subluxation. It's associated with a lot of clinical factors like pain, gait disturbances, neurological deficits, often warrants revision surgery. So, as I said, there's been at least 8 proposed definitions for PJK and PJF, but the one that I stated before is the one that most people go with. So, proximal junctional failure is PJF that requires surgical treatment, and it can be attributed to one of 4 main causes: fracture, spondylolisthesis, implant/hardware failure, and PJA progression. Compared with PJK, PJF is clinically a lot more significant with more pronounced ODI differences. In terms of classification, there have been a few classification systems proposed. The one that's most uniformly used, and I think will be covered in more depth in one of the later talks, is one by our own Dr. Hart, who proposed the PJK severity scale, which has, this is the scale on the right. It has 6 components: neurodeficits, focal pain, instrumentation problems, UIV or UIV plus 1 fracture, and the level of UIV. And you can see there's points associated with each category, and if the total severity score is 7 or greater, revision surgery should be considered, and they're doing a study right now to determine the validity of it. In terms of risk factors, proposed mechanisms include extensive paraspinal dissection at the upper instrumented vertebrae. So like accidentally exposing the next higher level would put you at a greater risk of this happening. Posterior ligamentous complex destruction, improper end vertebra selection at a transitional zone, severe proximal disc degeneration, UIV compression fractures, or UIV plus 1 compression fractures, that's upper instrumented vertebra, proximal instrument failure, and similar to extensive dissection, facet violation when it's otherwise unintended. Patient surgical risk factors, high BMI, low bone mineral density, that puts you at a twice as greater risk. If you're osteoporotic or osteopenic, puts you at a twice greater risk of having proximal junctional kyphosis. Older age at time of surgery, if you're over 55, you have a 3 times greater likelihood. They found that size of paraspinal musculature is associated with the ability to maintain sagittal correction, so extensive muscular dissection or extensive muscular atrophy pre-op puts you at a greater risk of this happening. Putting into kind of perspective the importance of PT in maintaining strong core stability musculature. Degree of pre- and post-operative sagittal malalignment, so higher thoracic kyphosis, PJA, pelvic incidence, pre-op SVA, overcorrection of SVA, these all increase your risk of PJK. Surgical risk factors, they found that pedicle-only constructs are associated with a slightly higher PJK rate compared to hook hybrid constructs. PLC disruption, obviously, there's a 3 times greater risk of developing PJK if you do a front-back front or front-back as opposed to just posterior instrumentation only. Also, if you have selected the UIV in the thoracolumbar junction, so lower than T8, you have a higher risk of PJK. And in this paper, they nicely outlined the risk factors and clinical importances of PJK, which I'll touch on in a second. In terms of prevention strategies, things patients can do, BMI optimization, using larger tricortical screws, using less rigid rods, sublaminar hook wire supplementation, Percutaneous upper instrumented vertebrae instrumentation can minimize the amount of dissection at that level. Cement augmentation at UIV or UIV +1 to minimize the risk of vertebral body fractures. Transverse process hooks at the upper instrumented vertebra. Terminal rod contouring, I thought that was interesting. How they mentioned how if you perfectly contour the top edge of the rod to fit into the screws so you don't have to reduce the top screws, it's obviously going to minimize your risk of PJK. So proper rod contouring seems pretty important. Ligament augmentation with Merceline tape, there's a picture of that in the bottom right. Also a minimally invasive approach to minimize muscular dissection when possible. 2 more slides. So this is just a picture of some of the Merceline tape options, cement augmentation options. And obviously the goal is to attempt to achieve an optimal age-adjusted sagittal alignment and correct PI lumbar low doses mismatch. That minimizes your risk of PJK. So in conclusion, proximal junction problems associated with higher morbidity, increased rates of revision. There's many definitions. The one that most people go with is proximal junctional angle greater than 10 degrees, at least 10 degrees greater than the pre-op measurement. And PJF is a progression of PJK requiring surgery. My time is up.
Great. That was terrific, Zach. Probably one of the better presentations I've seen on the definition. So terrific talk. And we're going to go to our next talk. And in the meanwhile, Jens, I wanted to ask you, do you really think doing Merceline tape and some of these other, do you think that really prevents PJK or PJF?
No.
So do you think, what do you think about hooks? What's your strategies on preventing? So our next speaker is Dr. Nathan Pratt. Nathan is going to talk about a nice review of some biomechanical studies about PJF and PJK.
Thanks, Dr. O. Hey, Nathan Pratt here. So yeah, we're going to look at a systematic review that assessed human and non-human animal studies on biomechanics of various top-end sort of soft transition zone instrumentation. So this is a systematic review looking at instrumentation techniques to reduce proximal junctional kyphosis and long segment fusions. The inclusion criteria were any human and non-human animal cadaveric peer-reviewed journal articles, assessing biomechanics with some sort of objective measurement of either interdiscal pressure or rotational stability, something like that, to evaluate whether these are providing some biomechanically measurable effect. So out of almost 3,300 articles that they searched, only 12 actually met their inclusion criteria. You'll recognize this slide. Dr. Tatarin just had this as well. This is just to make sure that we define the terms of what we're talking about. Merceline tape, so UIV, UIV +1, +2 being the vertebra above. They call the index level. So if that was T10, say, with the last screw in it, that would be 910. Disk space would be the index disk space. We talked about the tethers. They also talk about transverse process hooks in F, something that we use a lot, laminar hooks in E, and then vertebroplasty, which is kind of a little more difficult to assess biomechanically, but we'll talk about that in a moment. So let's go through a summary of the evidence that they present to us. Suture loops and tethers, so combination of Merceline tape as well as cables. Non-tension suture loops essentially had no effect on range of motion at the level of suture. Tensioned loops did reduce range of motion and intradiscal pressure at the index level, but multi-level tethers had an effect at the index level, but not index +1. So that UIV +1, UIV mattered, but the one above that, UIV +1, +2 did not. Crosslinks attached with Merceline or with cables did reduce range of motion as well, but this was only in the extension plane, not in flexion. And this was the interdiscal pressures as well, and that was at that index level. Sublaminar tapes, single segment did reduce interdiscal pressure and range of motion in both flexion and extension. Tape at UIV +1 and 2 had no effect on that index level +1. The concern was that overtensioning actually increased extension, possibly increasing posterior stress at UIV +1, similar to reducing onto a rod that would not be contoured properly. It's a similar concern that you're putting more stress at that top level and UIV +1. Laminar hooks showed variable results. There were significant reductions in, one of the studies showed significant reduction in range of motion in all planes, which was relatively comparable. This was 93%. This is compared to native motion at these motion segments. The authors of that concluded this stiffness is almost the same as pedicle screw fixation, so they question whether or not laminar hooks are a soft transition zone or whether they're actually should still be considered rigid. Another study by Metzger showed a higher range of motion in all planes comparing laminar hooks and pedicle screws, and the interdiscal pressures as well as the range of motion was decreased at the UIV +1, which is where the hooks would have been at that UIV +1 and at that index level, but was not reduced to the same degree as it was below that in the area of the pedicle screw construct. So they conclude that it is a softer transition. Transverse process hooks, this is something that we use very frequently here. Definitely a semi-rigid construct at the top of the pedicle screws. They had a similar cycle failure to pedicle screws, so their breakage rates, transverse process fracture rates were similar to the break rates they found when they were testing the pedicle screws. The problem was that they didn't compare this in the way that most people probably use transverse process hooks. They basically took UIV and switched pedicle screws for TP hooks. So if they were doing a T10 to pelvis, they just put TP hooks at T10 instead of pedicle screws, which is not the way I think most people use transverse process hooks. They usually would then go UIV +1 with those. So it's a little more difficult to interpret the differences between the pedicle screws and the TP hooks. Either way, they did present lower stiffness and flexion and extension at the UIV compared to pedicle screws, but did decrease the range of motion and the interdiscal pressures. They reduced stiffness by over 50% compared with the all pedicle screw construct, which is considered, theoretically is helpful in preventing proximal junctional kyphosis. So they, again, conclude that this is a pretty reasonable option. Just discussing the findings of the article, sutures and cables could reduce range of motion and IDP if tensioned, possibly reducing the stress transfer to the pedicle screw bone interface at the top level. Sublaminar taping does reduce the flexion extension, but only to 25% of non-instrumented fusion, which is similar to sort of to pedicle screw fixations, with possibly sublaminar. Oh, I'm sorry, that's sublaminar hooks, not taping. I apologize. Is possibly rigid, not semi-rigid. Laminar hooks definitely reduced range of motion, had less of an effect on interdiscal pressure, but were not as rigid as pedicle screws, unlike the sublaminar hooks, which sort of questionably were similar. Transverse process hooks appear to be a more gradual transition than pedicle screws. We didn't talk a whole lot about the bone cement because there aren't a lot of biomechanics to do there. It's not going to change your flexion or extension range of motion. It's not going to change the interdiscal pressure all that much. They basically looked at rates of fractures. They definitely decreased the rate of fractures at that top level and top level +1. And there are definitely translational and retrospective studies already looking at that, showing that cement augmentation at UIV and or UIV +1 can reduce screw pullout and reduce the rate of reoperation. Suture loops, so clinical significance, the loops in the cables do reduce biomechanical stress and potentially the rate of PJK, but there is some translational research to suggest this transverse process hooks and laminar hooks, both they're considering to have more of a semi-rigid fixation in biomechanical studies. The transverse process hooks, have been looked at probably more in the translational research, where they do show lower rates of PJK and proximal junctional failure. Vertebroplasty is reduced fractures and screw pullout. So what do we take away from that? Biomechanical data is unfortunately very heterogeneous and relatively limited. This is only 12 studies looking at this. Patient-specific factors and technical aspects of the surgery likely are more related to PJK than even some of the top-end instrumentation techniques. Biomechanically, all the techniques do show some ability to aid in a soft transition zone above the long spinal construct, and additional translational research is really going to be necessary to understand how best to use these techniques. They all show some utility. All are relatively simple, but which one is superior, which one will actually reduce your rates of proximal junctional failure, it's probably going to require even prospective study, which is going to be hard to do because of the heterogeneity of the indication for adult deformity surgery. It's not like, sort of adolescent idiopathic scoli, where there's a much more homogeneous population. A lot of people have degen, a lot of people have missed AIS that gets treated as an adult. So it's a little bit more, the granularity of the data is not quite as good usually. But anyway, that's beyond the scope of this paper, but hopefully that's helpful.
So what are your, so you're going to go out and practice in the next couple months. What's your takeaway from your experience here at Swedish? And then also, what's your takeaway from the literature review? Are you going to do a hook, sublaminar
hooks,
construct, Merceline tape?
Combination of those things. So I think that I really like transverse process hooks. I think that they're relatively easy to place. It's pretty quick. There's not a lot of there's a little bit of fiddling to try to contour the rod properly at the top because you can't reduce onto those hooks, obviously. So that adds a little bit of time, but not a lot. You disrupt a little bit of that ligamentous tissue already just dissecting for pedicle screws, so having something to reinforce that I think is nice. But we've done tethers around the rods at the top, which I like as well. Puts a little more stress holding them down rather than allowing them to back out. I think a combination of all the techniques based on the patient I'm treating. I think that Dr. Hart likes the tape around or the wire cables around the cross-link tensioning to put a little bit more force pulling back. I think all of those techniques in the biomechanical literature have some value. The one I've probably done the most is the TP hooks here, and I think that one's probably the easiest of those. Honestly, it doesn't take a whole lot of work to just recontour the rod a little bit.
Great job. Jens, you cut out. I think you were having some technical issues. Do you put TP hooks on every single T10 pelvis or deformity case? What's your take?
No, but first of all the discussions were very good. I think they were very complete. The one aspect that was not discussed is how high do we go? Do we go to the upper thoracic spine or the lower thoracic spine? Clearly, and this is where our partner, Dr. Hart, has had a great impact on literature. The rate of junctional failures is lower if we go to the upper thoracic spine, but obviously it comes at a cost of more surgery to the patient, perhaps longer recovery, perhaps even more occupational adaptations due to a reduced thoracic mobility, and obviously greater risk probably in general due to the extra 1 or 2 hours of surgery time. So this is an aspect we've not discussed or directly discussed. I personally do like transverse process hooks, and if I'm very worried, I'll add sublaminar cables to stabilize those a bit. And I may use rostral cement and adjacent segments with greatest possible care if I'm worried about bone. The key thing is, again, that as Zach had pointed out earlier, this is a multifactorial process. There's bone, there's soft tissues, there's the way we dissect and preserve or disrupt the soft tissues, and then there's a patient's own physiology in terms of how able are they to stabilize themselves. Do they have neuromuscular problems? So these are multifactorial things. Let me ask one more question. We have Dr. Derman there. And obviously, usually ask deformity questions to Dr. Lieberman, but in your observations and as a senior colleague who has run the QI committee, have you seen benefits or disadvantages of certain techniques? Is there a routine TBI strategy that you've seen? And is MIS truly involved with less roster junction failures? Thank you.
I think this is the $1 million question. I wish that I had the answer to it. It seems like there's all these various, techniques, but still we don't have an answer. As a guy who personally, I don't do deformity, I do all minimally invasive stuff. I can't say I have personal experience, but having seen at conferences, et cetera, all of these techniques being used, I can't say I've seen one that has been the winner yet.
Rod, for me, one of the biggest problems is, first of all, our decision making. But one of the biggest problems is postoperative rehabilitation. Let's assume we've done everything right. What frustrates me greatly is when patients with long constructs are mobilized and they're pulled up by their arms. When they're walking, they're standing on walkers and bending forwards on their walkers, which are invariably too far in front. And they're not taught how to maintain a truly straight posture and how to mobilize properly. And prone positioning or extensor exercises are literally not performed. So for me, this is one of those areas where we still need to kind of integrate multi-specialty efforts far better. I'll shut up. Thank you.
Yeah, no, I agree. Jens, those are all great points. So our next speaker is Dr. Jerry Robinson. So Jerry's one of our outstanding orthopedic fellows. He is going to talk about, he's going to do a systematic review on PJK after spinal adult deformity surgery. So he's kind of looking at a specific topic.
All right, thanks for having me. Are you viewing my slides well?
Yeah, looks great, Jerry.
Okay, all right, so everybody's kind of hit on things already. This is another systematic review, and this is PJK and PJF after spinal deformity surgery. And so you can see these aims and objectives down here on the bottom left. With their literature review, they searched phrases like proximal junctional kyphosis, failure, excluded any non-English articles, and then got rid of case reports as well. And their final lit review ended up with 53 articles. And so I'll go through each one of these aims and objectives to try to see what the literature has provided us. Keep in mind, my systematic review is from 2014, so it's a little bit earlier than previously presented. So some of the data is, or some of the talking points are similar to previous, but incomplete in comparison. So incidence and definition. So they found in the literature that it ranged from 5 to 46% of patients actually were seen to have PJK, but most studies reported somewhere between 20 and 40%. And of those who did get PJK, 66% occurred within 3 months, and 80% of those were in 18 months. So a little bit longer follow-up, and you'll probably get most of the patients that you see. Their definition, as Zach pointed out earlier, is defined somewhat inconsistently in the literature, but most defined it as 10 to 15 degrees of kyphosis compared to the preoperative measurements. And their measurement method was using the sagittal Cobb method, using the inferior end plate of the UIV and the superior end plate of the UIV +2. And you can see that on my picture on the right there. And PJF represented something different, and that was mechanical failure or instability above the construct, not just the radiological kyphosis. And so what is the significance of it? Like, so what? Some people reported it was just simply a radiologic finding, and others actually correlated it with higher rates of pain. But it likely represents a spectrum ranging from a benign radiologic finding to a more pathologic process that eventually leads to failure. And they did notice that some of the studies showed that when it was identified postoperatively, it can continue to progress up to 2 years afterwards. So really stressing the importance of long-term follow-up in these patients. And they did try to correlate it with a ultimate angle of kyphosis that eventually led to failure. And they tried to correlate, maybe saying around 27 degrees, maybe the the degree at which you see failure. And then again, definition of failure was kyphosis and structural failure, either of the posterior ligamentous complex or the vertebral body fracturing. And those patients were correlated as having worse ODI scores, higher pain, and higher rates of neurologic deficit. And so what were the risk factors? We talked on a lot of them recently, but older age, larger preoperative sagittal abnormal parameters, use of pedicle screws, not use of pedicle screws, use of hooks, thoracoplasty, getting rid of ribs, under overcorrection. I mean, I've heard everybody, a lot of people suggest differing factors for how they try to prevent or get rid of PJK. And believe it or not, straight to PJK, all of them. Everything I've ever heard ends up getting PJK. So I'm not sure we'd have the answer yet. But these were the ones that they tried to use as prevention strategies, and they reviewed in the paper. So I thought the vertebral cement augmentation data was actually fairly well summarized. They had low sample size studies that showed PJK, but they had some biomechanical studies that were not touched on previously. So I'll kind of go over those, but they basically loaded some cadaver bones and had a control and then stressed them. And they found that 83% fractured at that UIV or UIV +1. And so what they did was they did varying different constructs of using cement augmentation in these. And when you just cement the UIV, they had a 100% fracture rate. When they did the UIV +1 and the UIV, they had a 16% fracture rate. So I'm familiar with using the UIV and UIV +1, doing cement augmentation in the top two there. But other studies said that it's basically look at the preoperative bone health preoperatively, whether that's using a CT densitometry, using Hounsfield units or something like that, and going off of that to use your cement augmentation for. And then they touched on the cost effectiveness of using cement versus having to do a revision surgery. The cons of using vertebral cement augmentation, though, were in the kyphoplasty literature, up to 20% of those patients had adjacent level fractures. And I think a lot of us have seen where you inject cement and then you just get fractures around the cement at the level above or level below. You can have increased disc degeneration around that cemented vertebrae. And you can obviously get extravasation and decreased nutrient supply to that bone, which inhibits healing. They also touched on spinal hooks. Pedicle screws at the UIV are too rigid, so those studies showed higher rates of PJK or adjacent segment disease, which ultimately leads to revision. And then hooks at the UIV was a softer landing zone, and those studies showed lower rates of adjacent segment disease or PJK. And other things they touched on was Vector using the rib expansion or including a kyphotic level, so not stopping at a level that is kyphotic. But ultimately, I think they said that having a balanced spine or getting your preoperative balance was most important. And then lastly, no bias here, but I just wanted to touch on the best classification system. We got the heart classification. I have no conflicts of interest in why this was the best one, but basically they were able to say that a score of 7 or more correlated with the need for revision surgery. And as Zach alluded to earlier, they are doing some of the validity tests in that now. So if there's any questions or comments, we can take those.
So Jerry, I have a quick question for you. That was a great literature review. So you're going to go out and practice, and you're going to be out practicing in the next several months. Are you going to, what's going to be your strategy to prevent PJK and ultimately PJF?
Yeah, fortunately, I train here at Swedish, and so I think I've done all of these techniques, which is great for me as a fellow. And I think seeing complex spine pathology, I've seen probably every way of failure you can possibly see. And so I do think that I'm going to end up doing UIV +1 tethering on a cross-link. I do like that and tensioning that at the top. I also think that the data for vertebral augmentation is pretty good, but I think ultimately getting a balanced spine and a very well-optimized bone health patient preoperatively is probably my first and foremost. So delaying surgery until the patient has optimal bone health would be my preference. But again, that's obviously not always able to be done. So
that is wishful thinking,
I do
sir.
like those two.
Rod?
Yeah.
Jerry?
Yes.
So one thing, so I second, this is again, although there's an overlap, this is again a very good and helpful summary, and that offers some different perspectives. One question I had for Jerry and for you, Rod, is what I've not heard is intentional undercorrection. So with modern instrumentation techniques, we can actually reestablish a beautiful sagittal alignment. It's really amazing. But now there's some people who say we should identify at-risk patients and intentionally undercorrect the spine. So that's a major concern for me because, again, empirically speaking, my happiest patients are those where I've reestablished a nice lumbar lordosis and have a nice thoracic smooth curve. And now there are people who say I should intentionally undercorrect them, so I pitch their sagittal axis forwards a little bit, especially elderly female patients. So that's a concern to me. So I wanted to ask Jerry about that. And then I want to recognize that Dr. Huang had a good question again. That's if you put all hard versus soft landing elements in direct comparison, what is to be favored? So number one, intentional undercorrection, Jerry. And number two, address Dr. Huang's generalized question of hard versus soft rostral junctions. Thank you.
Yeah, so I actually think I've had the advantage of hearing both sides of that argument at SSF. We have a lot of speakers that, like you said, some have advocated for undercorrection or age adjusted or physiologic adjusted. And I think there may be some merit to that, but I don't know that the answer is there yet. In the age of big data, I think that answer is coming eventually for one of the key leaders in this area to eventually give us an answer to that. I'm not sure that there is a solid answer, but I always think that a better aligned spine is ideal. Delaying surgery to have optimized bone health, I think those two factors are probably the ones that I consider to be the biggest factors for preventing that. So I think in my practice, starting out using age adjusted and optimizing the patient preoperatively are going to be my strategies to prevent PJK.
So it sounds like you're going to try to do the soft landing.
Yeah, I do think the soft landing is a better alternative, using the Merceline tape instead of a TP hook or a laminar hook. I think that biomechanical data that Nathan presented was actually fairly convincing that, when you put a hook up there, it just makes it completely rigid, just like a pedicle screw. So I kind of like the Merceline tape pre-tensioned with the cross-link.
And I think location matters, don't you think, Jerry? I think Dr. Chapman pointed out, I think, I've had way more failures at T10 than if you go up higher at like T4 or T2. What are your thoughts on location?
Yeah, I think that might have some confounding in it. If we stop at a kyphotic level, that might be the ultimate answer rather than just the level. So I think it might be patient specific. Just looking at each patient individually and seeing if we're stopping at a kyphotic level may be more important than just the ultimate level. So getting past those levels of kyphosis is probably most important.
Great. Thanks, Jerry. I really appreciate your review, and I know it's been a stressful week for you, and I know you're on vacation right now, and it's so nice to see you, and we look forward to seeing you back on Monday. Are you coming back on Monday, or are you off still next week?
I'm actually on vacation. Believe it or not, I'm on vacation. I don't love traveling or being on vacation, but I won't miss these lectures. So
thanks so much for using your precious vacation time. We always love it when we can do this remotely. So our next speaker is Dr. Jared Cook. So Jared is going to talk about global alignment scores and increased risk of complications, and he's going to review a nice paper about it.
Yep, all of the scoring systems. Jerry, you really should have put Dr. Hart's 5-day beard into his photo. All the cool kids are rocking it these days. So my paper was, are high global alignment and proportion scores associated with increased risk of mechanical complications after adult spinal deformity surgery and external validation? So this was done in 2020. So essentially the question that they're asking is, after adult spinal deformity surgery, is a higher GAP score associated with an increased risk of mechanical complications, proximal distal junctional kyphosis or failure? Is it associated with a high likelihood of undergoing revision surgery to treat a mechanical complication? And is a lower, AKA a more proportioned GAP score associated with better validated outcome scores? And they looked at the ODI SRS-22 and SF-36. And so, you know, this supposedly had been, you know, validated previously, but so the question is, why are we asking this question seemingly again? And they identified that there were methodological limitations in the original GAP score external validation study. Basically, the original methodology for the study that they were working off of, they didn't quite follow that. The sample size was small. The original inclusion criteria were not actually followed, and then there were just some vague definitions of, quote, mechanical complications. And so, you know, they went to the original study. They looked at the 272 patients that were that had corrective surgery for adult spinal deformity that were previously enrolled in the SCOLI Risk 1 prospective trial. So tried to use the same data, and they did their analysis fulfilling the original inclusion criteria from the Yilgor et al. Study. And so out of that, 59% of those patients were available for analysis after 2 years. There's mostly female. 12 plus or minus 4 levels fused, and 76% had 3-column osteotomies. So their inclusion criteria, you know, followed the or inclusion and external or exclusion criteria followed the original. So that was age greater than or equal to 18 years, at least one of the following. It's the scoliosis greater than or 20 or greater degrees, SVA 5 or more centimeters, thoracic kyphosis greater than 60 degrees, pelvic tilt greater than 25, 4 or more vertebrae instrumented in the fusion, minimum of 2 years follow-up, and the exclusion criteria included neuromuscular disease, active infections, trauma tumor, no full-length x-rays available at baseline to compare it to, strictly early post-operative period. That's what they define as 3 to 12 weeks, and planned UIV within a previously fused segment. And so they calculated the GAP score, you know, using previous parameters, using the pelvic incidence, sacral slope, lumbar lordosis, both at L1 to S1, and then the L4 to S1 lordosis. And global tilt, the GAP scores were, the proportional category was a score of 0 to 2, 3 to 6 is moderately proportional, and 7 to 13 is severely disproportional. So basically your lower score was seen as better. And here's what they found in the results. There were mechanical complications, seen in all the categories. Proportion GAP score is 13%, severely disproportion was 31%, and after their statistical analysis, it showed that a higher GAP score was not associated with increased risk of mechanical complications. For revision surgeries, after their statistical analysis, the higher GAP score did not associate with a higher likelihood of revision surgery to treat mechanical complications. The only things that they really got were that the moderately disproportionate GAP score was associated with better functional outcome scores compared with disproportionate GAP score. That was kind of it. And they noted that they really did have some significant limitations here. So, as previously stated, only 59% of the patients in this study actually, met inclusion criteria. So we're pretty limited in the numbers. The database patients had more complex deformities than the original GAP study. There was not an even distribution in GAP score. The study was not designed or powered to validate the GAP score either. So the conclusion is basically setting alignment targets based on GAP score alone does not actually contribute to knowing your risk of mechanical complications or revisions for that. And the patient population is just, too heterogeneous. There were multiple comorbidities, smokers, multifidus center erector, muscle quality, thoracolumbar muscle volume. All those things have been studied and shown to have some effect on the outcome, and these things were not taken into into consideration. So there's just more to look at than just strictly alignment, and so this study, called into question the validity of the GAP score. Basically, it doesn't, seem like it's a very useful tool to hang our hat on.
So what's your takeaway from your year here at Swedish, the papers that we just reviewed, and your own personal experience, Jared? What are you going to do? Are you going to do like a different technique for each case?
No, I wouldn't say I would, do a different technique for each case. I mean, it's it's much better to have, something that works very well in your own hands, something that you can consistently, perform well. That might be a couple of different things, but generally, if you, try to do everything, you might not really be good at any of them. Consistency is important. I think that when looking at this paper in particular, my takeaway from this is that you can't look at kind of this one isolated factor and plan your entire surgery around it. There are too many things to take into account, and so my answer really just mirrors what Jerry's was, and I've never even seen people use the GAP score, so it's that's not even going to be on my radar.
So you're gonna basically take a little bit of everything and try to optimize like rod contouring. Are you gonna put TP hooks, or are you gonna do the soft landing?
I think the soft landing is going to be preferable. So that's actually probably the technique that I'll use. And seeing that T8 is kind of that that cutoff area, I'll take into consideration. I think that ending on a kyphotic segment or ending just below a kyphotic segment is setting yourself up for failure. So that's another thing that I'll take into account. So essentially, it will be a gestalt with some patient-specific characteristics taken into account, because ultimately every deformity has its own characteristics. Everybody is different to some degree, and so alterations will be made as necessary to the kind of overall consistency that I'll use.
Great, thanks, Jared. So our next speaker is Yev Fravert. Yev is one of our outstanding fellows. He did his neurosurgery residency at UCLA, and he's heading to Texas next year. And he's done some great work this year, a couple of research projects on prone lateral. He's got a wide array of research interests, and I thought that this paper was a great paper for Yev to review, and it discusses using Hounsfield units and looking at other ways to assess bone density. Hi, Yev.
Good morning. Can you hear me?
Yes. How are you doing?
Fantastic. Not too bad. Sorry, I can't be there in person. I'm at the Global Spine Congress here in Vegas, and yeah, this paper definitely definitely aligned with some of my research interests. So it was a good choice. So the paper in question is titled "Association between Lower Hounsfeld Units and Proximal Junctional Kyphosis and Failure at the Upper Thoracic Spine." Sorry, give me 1 second here. Having a little bit of trouble with the slides. Okay, are you able to see my slides again?
Yeah, we can see it nicely.
Fantastic. So the background, as you know, we've heard from all of the other presenters, PJK and PJF are pretty common postoperative complications, especially after long segment spinal fusion. We've already discussed, many of the strategies to mitigate PJK, PJF, but they include proper anatomical distribution of lumbar lordosis, good selection of the UIV, all these soft landing zone techniques. Kind of newer things are age adjustment for alignment goals, and then obviously bone mineral density optimization. Historically, bone mineral density optimization required DEXA scanning to be performed, but more recently, CT densitometry has been used as an alternative due to various factors that make it logistically superior. And the present study aims to evaluate the predictive value of specifically CT densitometry for bone mineral density evaluation with respect to PJK, PJF risk of the upper T-spine with long segment fusions. So the study design, we're looking at a single multi-center institutional chart review, looking at patients from 2008 to 2019. All of the patients that were selected had pelvis to T1 through T6 fusion. Those were the UIV for every one of these patients. Minimum patient age was set to 50, and then all patients had to have preoperative CT and postoperative plain films available for evaluation. They set their minimum follow-up to 1 year, and all of the patients had to have no prior UIV or UIV plus 1 instrumentation just to facilitate measurement of CT bone density. Ultimately, the authors found 81 patients that they could include, although they didn't provide any additional information regarding the number of patients that they excluded according to their various criteria. In the top right there, I have an example of their measurement technique where they take three axial cuts through each vertebra to measure the bone mineral density. This technique is becoming fairly standard in the literature. I think the majority of CT densitometry studies have adopted this specific method. Other data collected by the authors were included basic demographics, relevant medical history, ASA classification, the CCI, and modified frailty index. They also collected various operative details and pre- and post-operative spinopelvic parameters. So these are the results, and it's a very large study. I only selected a few things, and just very briefly, kind of in line with what the other presenters mentioned. PJK for this study was defined as a greater than or equal to 10-degree change between postoperative films and immediate postoperative films and final follow-up, and then PJF was defined as fracture, fixation failure, or kyphosis requiring surgical revision. So in the top left there, you have the patient demographics spread across all patients, and then the groups that experienced PJK or PJF, and those without PJK and PJF. Not really anything remarkable there. One thing to look at is the distribution of UIV among all the surgical cases that were selected. Perhaps unsurprisingly, T4 is the most popular, and that does seem to be the trend in clinical practice that I've seen as well. So their study mirrors that. And then in the top right, you can see the spinopelvic parameters, both pre-op and post-op, as well as statistical analysis demonstrating that there were significant changes to everything that they measured post-operatively, except for pelvic incidence, which is what you might expect, given that that's a fairly fixed parameter. But everything else, SVA, pelvic tilt, everything was found to be different preoperatively versus postoperatively, and that's reassuring. That means that they were achieving some element of deformity correction with all of these procedures. Kind of the more interesting results were the actual analysis of factors influencing PJK PJF probability. Sorry, the font I'm sure is a little bit small, but some of the salient factors were bisphosphonate treatment. That's probably not an implication of bisphosphonates themselves, but rather just kind of something that's correlated with pretty advanced osteoporosis. And then most interestingly, relevant to the core topic of this study is that they found the mean Hounsfield units of the UIV and UIV +1 were highly predictive of risk of PJK, PJF. They also measured the CT densitometry of the lumbar spine, and they found that was associated with increased risk of PJK, PJF as well. And then there were some other factors that I won't dwell on. On the right side there, you can see the receiver operator analysis, the optimal cutoff that was identified was 159 for the Hounsfield units, and then they split their patients into three groups with the lowest bone mineral density, intermediate, and then highest bone mineral density. And you can see pretty definitively as you head lower in terms of CT measured bone mineral density, the risk of PJK, PJF increases very substantially. So to wrap things up. This study is pretty comprehensive. It certainly analyzes many PJK, PJF predictors and focuses on CT BMD analysis. The study was purposefully limited to very large constructs that terminate in the upper T-spine. This was by design just to make sure that the patient population was homogeneous, but also limits the generalizability of the study to some extent. This study demonstrates the significance of CT-BMD at the UIV, UIV +1 as a predictor of PJK and PJF pretty definitively, I would say, in my assessment. Of course, it's hampered by all of the usual factors that are intrinsic to a retrospective chart review, and certainly a prospective study would be better, but obviously that would be pretty difficult to execute.
So yeah, that was a great review and an excellent paper. So you're going to go out and practice as well in the next couple months. So what's your strategy on preventing PJK and ultimately having PJF in your practice? And what have you learned in the last year?
I'm not entirely sure that all PJK and PJF is preventable. I think the take home from many of these studies is that even with optimal patients and strategies, you're still going to get some. But certainly, patient optimization, good preoperative patient optimization is very critical. I think the study I just presented showed that having a CT bone mineral density of the UIV and UIV +1 above 195 was highly protective for PJK, PJF. I'm not necessarily a strong believer in the soft landing zone techniques, although they do seem to be at least partially validated by the literature. I think what's most intriguing is the kind of the hybrid technique where you do a partial minimally invasive approach to the UIV and UIV +1. I think that's something that I'll certainly try in the future. Perhaps perc screws for the upper two levels just to minimize disruption of the anatomy. See how that goes. There seems to be some evidence in that direction. And then the other thing is just very good postoperative PT. Just make sure that the patients are getting good nutrition. Just facilitate healing as best as you can.
Great, thanks so much, Yev. So I'm going to hand it over to Jens to close us out. I really appreciate all the great talks. today, and this is an important topic. I think there's, as you guys pointed out, there's lots to learn, there's lots unknown, and there's definitely more to do. So, Jens.
Thank you, Rod. Great job. Thank you, SSF. And congratulations to our fellows. All of them did a very good job. We don't have an answer to proximal junction failure or kyphosis. We clearly have to educate our patients about this possibility. This is a multifactorial process, and we will need to have a much better risk analysis strategy. So we have risk coefficients for all of these factors. But again, right now we need to educate our patients. We need to take the time to pre-add them where possible. And we have a number of options available to diminish the effects. We don't have an answer. With this, I thank you, and thank you, Rod, for putting this together so nicely, and all of the fellows for their great contributions, and all of our viewership for being interested in participating in SSF. Thank you.
Great. Thanks so much, everybody. Happy Friday, and I hope everyone has a great weekend.